Hello, my name is Eddie Lashley. I'm currently a paramedic with First Health, Montgomery County. Today I'm going to demonstrate for you some good practices in patient charting documentation. At First Health we use ESO for our patient call reports. This exercise is I'm going to show you on the laptop here some good techniques for clear and concise documentation of just a routine chest pain call. I will focus on the patient assessment and flowchart documentation. Your initial assessment on any patient is always critical in developing a treatment plan. What should you expect when you approach someone with chest pain? We all know chest pain can be very vague. It can be a life-threatening acute onset complaint, or it can be totally non-essential. What makes chest pain treatable? What are critical findings relative to differentiating acute versus chronic chest pain? I want to just demonstrate for you here a call report. I'll give you a little scenario of the information that's known. You have a 74-year-old black female. It's 3 o'clock in the morning. You respond to her residence. She's awakened from sleep complaining of acute chest pain. Sample history is just a history of high blood pressure, high cholesterol, and gout. She's allergic to sulfa. She takes lisinopril, Lipitor, and allopurinol. GCS 15, no syncope, no shortness of breath, 9 out of 10 pain, skin pale and dry, strong irregular radial pulse, lungs are clear. Her feet are swollen, and she says she's had difficulty getting around the last 2 or 3 days. So first I want to show you just the tabs. We'll go to the patient tab and we will document the history. One of 2 ways you can do this. You can type it out. You can actually search it. I like to type it out. It's easier and quicker for me. But either ways, what's easy for you. I can type faster than I can search. So we know hypertension, gout, and hyperlipid. Sulfa's pretty easy, so you can just type it, search it, and it's there. It'll pop up for you. There you go. Meds, again, you can search out the meds, but all the meds aren't in the bank, so it's quicker sometimes to type it out. We got Lipitor, allopurinol, and what did we say? Lisinopril. You gotta be able to spell when you do this part too. Okay, now, first we're going to focus on the assessment. This is where your chart's going to really flow, give you a good kind of general impression of what's going on when you get to the patient. So we're going to use a patient contact time of 3:04, and it starts at the top with her mental status. Her GCS was 15. She's alert and oriented. Here at the bottom, you can type GCS of 15. With chest pain, she said she didn't pass out, so we can use that as a pertinent negative. No syncope. Skin color, she was pale and dry, so we don't want to click the universal pink, warm, and dry because that wasn't accurate. So we'll just click pale, and we can type pale and dry. Head, eyes, ears, nose, throat. Nothing going on there that we noted. Did you look at her pupils? Just a quick glance is all you need for her. She was equal interactive. Your baseline pupils are 4. Another pertinent negative, JVD. She was sitting up right. You'd probably be able to see that pretty easy. So that was negative. Airway was patent. And a common acronym here to use when everything's normal is NCAT, normal cephalic, atraumatic. The chest, 2 things here can be kind of written down or assessed is objective and or subjective findings. If she tells you she's short of breath, you can click yes for accessory or no. She was not short of breath, so another pertinent negative, no accessory muscle use. Heart sounds, did you do it? Did you listen to heart sounds? Let's say we did and they were normal. Then both negative. Universal click at the top for lung sounds, clear and equal bilaterally. That automatically defaults your adventitious sounds to negative. So she was clear. Another type out here at the bottom. Clear and adequate. That signifies no shortness of breath, lungs are clear. The chest pain, she described it for you. Subjective term, sharp, crushing chest pain. Here you can just say acute onset. Crushing chest pain. Next is our belly. Pertinent negatives, nausea, vomiting. Did she have those complaints? She did not. So negative on that. Did you palpate the belly? We did. There was nothing going on there. Round and soft.
Mom, it's cold.
Round, soft, non-tender. Next is the back. Nothing with the back. She didn't tell you she failed during the night or failed getting up. Atraumatic. No trauma. All pelvises are stable. Okay, the extremities, we found some abnormalities in the legs, in the feet. So left arm, no, left arm normal, right arm normal. Left leg, she said she had trouble getting around last couple days, so you got weakness in the lower extremities with edema. Pulse, all you have here is normal or not normal. So even though it was irregular, it was normal as far as this assessment goes. Cap refill, did you check it? Let's say we did in the legs and the arms. Nothing going on, all less than 2. Here we need to define in the extremities, weakness, presence of it. Is it normal, is it not, or any objective trauma if you're documenting trauma. So she moved all her extremities. The lower legs were weak. It has been a relative new onset for 3 days. The edema was present in both feet. And then neurological, no abnormalities. Gross motor neuro intact. Okay, that defines your initial assessment. You can go back to the top and just kind of see you got everything in there. Next, we go to the flow chart. All flow charts should start with an ALS assessment. It should reflect the same as our patient time. And we're basically just typing out just a short, brief comment of what we found. 74, black female, consular oriented, severe, crushing, chest pain, 9 of 10, no shortness of breath. Skin pale. Don't have to get really in-depth here. That's usually just a nice overall contact time. All right, what's important when dealing with chest pain is a treatment plan. So just based on our initial assessment and what she's told us, we're thinking we're probably going to want to assess this pretty quick and get treatment going. So the first medicine, obviously, we can give as we're talking to her is aspirin. So go to your flowchart medications, and at the top right, you see aspirin. It automatically pulls up your 324 milligrams. Say we give that 305, good to go. So aspirin done. Next, put it on the monitor. Cardiac interventions or monitors EKG assessment is under other, 3 lead. Let's say 307. And what was it? Just a simple, let's say it was sinus rhythm. Just note the rate, irregular. Say they were PVCs. If you got the pulse ox on right here, measure at 98%. Okay, next comes obviously the 12 lead. So let's say a couple minutes later, 309, you have a 12 lead. Here, don't put normal. Document the 12 lead. What's there? Are there changes? And if so, define the changes. So sinus rhythm. Say the PVCs were unifocal. Axis is real important most of the time. You can just type normal axis. And STT changes. This instance, there were none. So clean 12 lead. It takes 8 seconds to type all that. And it says, defines the rhythm, ectopy, ST changes yes or no. Okay. So we got aspirin on board, a normal 12 lead, 9 out of 10 chest pain. Next comes nitro. Okay, so before we get there, we're going to have some baseline vital signs. These will be imported later on at the end of your call. But let's say her initial blood pressure was 164 over 90. So with that being said, she can get nitro. Again, medications table. You have two. You have paste and nitrostat. Nitrostat is your individual sublingual doses. So let's say at 310, right as that 12 leads printing out, we see there's no acute involvement inferiorly. She can get nitro. At 310, it automatically pulls up 0.4 sublingual. The comment, first nitro, 9 out of 10 chest pain. Just to kind of keep in unison of your individual doses. So that's the first one. Let's say now we're going to work on getting her to the truck. And we're going to get an IV going. So it took us a couple minutes. IV therapy. Let's see, at 314. And just go down each field. On the saline, say we got an 18 in the left forearm. Flushed it with 10. It was successful. It was patent. So just type of patent saline lock. Good to go. All right, IV's done. IV's good. Time for that second nitro at 5 minutes. So 3:15 comes our second nitro. And we ask her, ma'am, how's your pain after that first pill I gave you? She said, it's still there, but it's better. It's a 5. So second nitro, 5 and 10 chest pain. And now here, we're kind of at a part in the protocol where we can divert to morphine, or we can give that third nitro and see what happens. Let's decide to go with that third nitro at 320. And you ask her again, ma'am, how's your pain now? And she says, it's gone. It's completely gone. Thank you for whatever you gave me. So now we can document third nitroglycerin, 0 chest pain. And we're not done yet. Pain-free chest pain patients after nitroglycerin therapy, if they become pain-free, they get nitro paste. So that is also under medicines. What's her pressure now after the pain is gone? Let's say it's 144 over 88. And let's say 323. 144/88 gets 1 inch. Systolic of 100 to 150 gets 1 inch. Gets 1 inch of pace. Transdermal, and there you go. You can just put pain free. Okay, now looking at that from top to bottom, you can see everything kind of flows, and even not even knowing anything about this patient, I can scroll through this flow chart and tell you basically what went on this call. Back to the assessment, everything flows. Kind of a clear picture of what's going on. And you can just scroll through and see. In your ongoing assessment, you can document the improvements you had. Her skin was pale, it improved. The chest pain went away with 3 nitros. And this kind of sets a nice, easy flow for documentation. Thank you.